Next video we're going to touch on is elbow arthritis, and it's something that I think really kind of scares people a little bit along the way. Certainly scared me when I was preparing for this, and it's not as intuitive as other joints that we look at, and unfortunately you can't just learn how to treat knee OA and then apply it to the elbow because it's not quite the same. So this is a very different beast, and I think that you're going to have to change your thinking entirely on this. Primary OA of the elbow is incredibly rare. It's really not something that happens. And if you think it's happened, you should probably start thinking maybe there's an inflammatory arthropathy going on here somewhere. The biggest reason for it following inflammatory arthritis is trauma. So if you're thinking to yourself, oh, this is primary OA, this is something that just happened and there's no reason for it, because of the nature of the elbow not being a commonly axially loaded joint, it's not something that happens generally. It's just not the way it goes. The secondary causes, so therefore something else happened first. So if you think that this secondary element of OA, then you have to think, well, what came first? And that will change how you manage things. So if it's post-traumatic, you can kind of predict where the issues are going to be. If they've had osteochondritis dissecans, again, it's going to change where the issues are, where the pathology is, and how you're going to approach it. If they've had any osteochondromatosis, again, this will change things. And if you've had a muckle or ligamentous insufficiency or a luckle, as we've seen in the stability video, insufficiency, it will also change what you're looking at. Now, if you're considering the pathoanatomy of secondary OA of the elbow and post-traumatic, you will get very similar concepts to what you see in other joints. You'll get the osteophytosis, you'll get the contracture of the capsule, you'll get loose bodies, you'll get osteophytes around the articular surface that block motion, and then you have to remember that this affects the radiocapitellar joint far more than the ulnohumeral joint with regards to the actual loss of articular cartilage. That is not to be confused with the fact that the coronoid overgrows, the olecranon overgrows, and both fossae of the olecranon and the coronoid also overgrow with additional bone. So even though it says here that the RC joint is vastly more affected than the UH joint, that does not mean that the UH joint entirely is spared. It only means that the cartilaginous surfaces or the articulating surfaces of the ulnohumeral joint are spared in favor of the radiocapitellar joint. Now, if the RC joint is involved, then obviously you can assume that the pronosupination is going to be painful in isolation. So flexion extension is often quite comfortable. It's just stiff, it's not painful, but the rotation from pronation to supination is painful at that point. You do preserve the range of movement of the radiocapitellar joint because you don't get that bony block with regards to how things are moving, and the flexion itself is what's lost, not the pronation. So there's kind of a robbing Peter paying Paul between them. You lose movement in the UH joint in favor of not having pain. You keep movement in the RC joint, but you do have pain because of the cartilaginous loss. So just in knowing that history and understanding what the patient is going to complain of will help you in figuring out where the main pathology is. The post-traumatic arthritis, as I've touched on, is the most common cause after an inflammatory arthropathy, of which rheumatoid is the most common, and therefore the most common cause of non-inflammatory arthritis is post-traumatic arthritis. It is not primary OA. You get direct cartilage damage because of the injuries. You get an incongruency of the surface. The load distribution is altered, and this isn't new information to you. I mean, this is the very reason that we want to make sure that the tibial plateau width is maintained so that we don't have point loading. It's the very reason that we want to make sure that the articular surface of our humeral head following a four-part fracture is restored. And if there isn't a possibility of restoring it, we then go down the road of doing an arthroplasty because we know that the incongruency of the cartilaginous surface will result in post-traumatic arthritis. It's generally one specific joint. With this, you can have ulnohumeral involvement because of the fact of a transolecranon fracture. But again, generally speaking, you just need to be aware that its secondary cause of the final OA is because of the traumatic injury in the first place. The way patients will give you the history is they'll say that they'll have a bit of loss of range of movement and it's progressive. So progressive stiffness, contracture, and then plus or minus having an association with a non-union or a malunion as you go on, but that will be dictated by you and looking at the x-rays. As we've touched on the other video as well, if you don't understand the anatomy, you can't understand the pathoanatomy. And then when you're taking your history, you are really just having a shot in the dark and you're not sure what's going on. And my biggest fear with this is that you can't manage them correctly, and you do one of two things generally. You may get lucky and hit the sweet spot, but you're more likely to either undertreat them or overtreat them, depending on the options you've offered, because you're not fully aware of the pathoanatomy of what's going on, the natural history of the injury and where you should intervene, who can you sit on, who can you wait, and then who do you need to intervene on a bit earlier. We've touched on the primary stabilizers as well, that the anterior band of the MCL is the main one in extension. So therefore, for distraction of valgus forces, your anterior band of your MCL is your main friend. Your lateral complex, or your ligamentous complex on the lateral side, made up of your AL, RCL, and your LUCL, are very important. And then we also talked about the bony structures of the coronoid, the trochlea, the olecranon, and the fossa on either side of that trochlea as well. This paper I've touched on in the other video, where they talk about the stability of the elbow depending on active movement of the muscle in favor of passive movement of the joint and the pronated position of the forearm. Now, we've touched on this particular picture, but more importantly, what I wanted to show you also was this is actually the abstract from that paper. And they talk about the gross instability that was present after the LCL was transected with the arm in varus. Now, they also then go on and say that the structural integrity and the stability of the LCL deficient elbow was similar to the intact elbow if you brought the forearm into pronation. But if you brought it back out of pronation and back to neutral or supination, you did not have the same stability that was maintained. Active flexion, when they simulated it, resulted in better stability than when they went ahead with passive mobilization whilst avoiding shoulder abduction. So the big thing is that if you bring your shoulder into abduction, you then bring your elbow into a position where it can drop off because of the lateral complex deficiencies. So this is where we come into the rehabilitation. You can do rehabilitation with active elbow movement, and it's encouraged over passive because we activate it. If you're worried about the ulnohumeral sag, you do the rehabilitation in the elbow with the arm up over the body, with them lying supine, so gravity is pulling them downwards. And separate to this, then you do it with the arm in pronation, and you don't bring the arm out from the side. So it sounds kind of complex initially when you say, oh, no abduction, pronation only with supine active movement for the ulnohumeral joint. And it sounds a bit complex, but actually when you understand the literature, when you understand the stabilization effects of various ligaments and positions of the bony structures, you then know why you're doing that. You're not just picking it out of the ether to figure out what's going on. The secondary stabilizers are really important. So the radial head, I feel, is definitely an unsung hero in the elbow. It's the most important of the secondary stabilizers, and we've talked about O'Driscoll's secondary stabilizers of the internal fortress. So you've got your CFO and your CEO, but primarily is the radial head or the radiocapitellar articulation. It gives you 30% of your valgus stability. So think about this now. If you're looking at your valgus stability and you're focusing on your MCL, well, only 70% of it comes from everything else. 30% comes from the radial head being at the correct length and being able to take load across the radiocapitellar joint. The other thing as well is you need to remember that it's most important in 0 to 30 degrees of flexion and pronation. As we come up past 30 degrees of flexion, the radiocapitellar articulation has less importance because the PCL, or the posterior band of the MCL of the elbow, comes into effect and the ulnohumeral joint starts engaging with that coronoid tip around the front. The capsule itself is the primary restraint as well to distraction forces in full extension, but overall it does give you some secondary stabilization as we come into flexion. And then remember that your lateral capsule and your anconeus are secondary stabilizers to the varus force. So that's why we don't like to bring the elbow or the forearm or the upper limb into abduction during that rehabilitation phase of the first 6 to 12 weeks. Now, the treatment of elbow OA is the thing that I was referring to that is not as intuitive as you might think when you think of hips and you think of knees. And even when you think of shoulders as well, the shoulder lends itself a little bit more to the hip. The elbow and the knee are not synonymous with each other in the sense of both of them being hinge joint. Now, the first option for everybody is obviously do nothing. And the phrase I have for patients in clinic is, I go home, you go home, and we never talk again. And that is a viable, valid, and appropriate treatment option in certain patients. The non-operative stuff, you have to rattle through this pretty snappy in your exam because the examiners know that you can do this. Rest it, move it, physio it, anti-inflammatories, increasing the WHO, opiate ladder and analgesia ladder and yada, yada, yada. And you know that, and anybody can tell you that from their first year out of medical school. But then we talk about the surgical interventions and what are on offer. Like I've said already, if you don't understand the pathoanatomy, you can't then talk about the solutions to the surgery, or solutions to the problem. So treat the problem that the patient presents with. Treat the man, not the scan. Treat the patient, not the picture. If we go back to this slide already where we talked about osteophytosis, contraction, loose bodies, osteophytes that block the movement, and then also the RC joint being more involved than the ulnohumeral joint, then you can kind of get a picture of what's going on. So this will be dictated by your history, your physical exam, and your imaging. And that will then help you plan what you're going to do for the patient. So the options that you have in, not necessarily in increasing interventions, but ultimately in a kind of a progressive way, would be arthroscopic debridement and capsular release, or what's also known as osteocapsular releases as well. The ulnohumeral distraction interposition arthroplasty, again, it's not that favoured because of the outcomes and the intervention of it. Olecranon fossa debridement only, which used to be what they used to do if they didn't want to go through the back or open up the elbow completely, which is known as an outer bridge Kashiwagi procedure, or also known as the OK procedure. And you literally take a burr, drill through the front of the olecranon fossa, and take out the osteophytes at the back from the tip of the olecranon. The column procedures being medial or lateral, and more so lateral than medial really, and then finally moving on to arthroplasty. Now the column procedures are, when you read about them, they sound like a little bit of black magic, but actually you're simply doing what you're doing in the arthroscopic debridement and the capsular release, but just being quite aggressive with it and going straight across the front, straight across the back, stripping the capsule off, stripping all of the excess arthrofibrosis off, and then excising any of the osteophytes. That's as simple a description as I can give you of a lateral column procedure, or the medial side as well. Arthroplasty then is something that is reserved for low demand patients, or a salvage procedure depending on the amount of damage that you have with regards to the actual presenting complaint. And it's something that it really is a last resort, whereas in a lot of other joints, it's almost the gold standard that we go to, whereas arthroplasty for the elbow is certainly not the case. If you consider the debridement of the capsular release, the way orthobullets will break it down is at your indications and your contraindications. Now, if you've got mechanical symptoms from loose bodies, then you're obviously going to go in and fish them out like you would do with any joint. Stiffness related to the capsular contracture depends where you're stiff. Are you stiff with flexion? Are you stiff with extension? And with that, does your x-ray or your CT show that you also have an associated bony block? And then generally, the arthroscopic debridement or capsular release is favoured in patients who have greater than 90 degrees of motion. If you're mid-range stiff and you are literally at the point where you're doing this, you're not really going to get much of a benefit for patients with an arthroscopic debridement, because there's a lot more going on and you're going to have to do an element of an open procedure for this. If you have severe contractures, as we see in the contraindications, it's not really a good idea to try to go in through this. You'll swell the joint, you'll distract tissues, you won't really get the effect you want, but you'll have all the risks. And also another contraindication is previous ulnar nerve transposition, because you haven't a clue where that nerve is and you can't do it arthroscopically. If they are tight at the front and they have a bony block to flexion and you can get them fully straight, you know that it's not the olecranon fossa at the back. But then you're thinking that they're maybe just short of it, but they don't have an olecranon block, then you only need to go to the front. You'll look at the back, but you don't need to do much work there. If they can get full flexion, but they can't extend, then you're thinking, well, actually, it's probably the anterior capsule and bony block at the back. And generally, I think of it as opposite sides, bony block on one side and contracture of the capsule at the other side, so front and back or back and front. But generally speaking, you'll find that a lot of patients will need some work done at the front and the back, and also clearing the fossae at the front and at the back as well. If you are looking at the flexion side, though, you need to be aware of the ulnar nerve. If you've restored flexion, you can have an ulnar nerve neuropraxia because you're tightening them in the cubital tunnel. So a lot of people will talk about needing to do a cubital tunnel release, plus or minus a transposition for these patients as well, depending on how the nerve is behaving. But that will ultimately depend on, firstly, what their ulnar nerve symptoms are, 2, how much range of movement you get back for them, 3, if you do decompress them, are they stable? And if not stable, you need to then stabilize them with a transposition. The interposition arthroplasty, again, high demand patients with end stage arthritis, and ultimately you're thinking we have no other option other than a total elbow arthroplasty, but you're far too young for it, so we'll kind of throw the kitchen sink at it and do an interposition arthroplasty. The great thing about it is, though, is that you don't need to put any lifting restrictions on them like you do for a TEA. The big problem here, though, is you have to have a perfectly stable elbow, and we've already talked about O'Driscoll's fortress and knowing what you have with regards to the stability of the joint from a bony osseous structures and also the secondary stabilizers of the soft tissue element. The technique then can be either a TFL, autogenous graft, or Achilles. I've seen other people do a palmaris longus graft as well, but it depends on the thickness, because you're trying to cover enough and you don't want it to be a small thin band running down the middle of the joint and subluxing inside in the joint and jumping. So you need to have a big enough strip that's strong enough as well to take that constant gliding movement as well. This is a staging procedure, really. You're looking at the patient needing a TEA later on, but ultimately there's nothing else you can offer them because they're too young. If you go on to the OK procedure, again, it's something that's interesting to look up, but generally now that we have the arthroscopic stuff, this is often just chucked in because you can go straight through the front if you're struggling to get to that olecranon fossa initially, but it's not the end of the world if you have an olecranon fossa void, provided you have 2 normal columns of the elbow and your fossa here is being debrided out at that point. As I've touched on, your burr hole through the olecranon fossa remove the osteophytes and the arthritic bone, and it increases the range of movement in extension. It has nothing to do with the flexion. The flexion side of it then would only be if you had a huge amount of bone at the front for the coronoid fossa, which joins into the olecranon fossa through that thin sleeve of bone. But again, generally the OK procedure specifically refers to olecranon fossa debridement through the front to the back. Complications are ultimately that there can be a failure to address the anterior osteophytes or peripheral osteophytes on the medial and lateral olecranon. Because of that view that you're trying to get straight down the middle, you may not get around the corner and may not be able to get to that point that you want to hit. So this is why the arthroscopic debridement has kind of come to the fore, because you get a full view depending on where you put your portals. The column procedures is something that again is ultimately kind of like a revision procedure, and some of the surgeons here have said that if you've been in the joint once, you have to do an open procedure, and it's a bit risky going in to do the arthroscopic stuff, mainly because of the arthrofibrosis, even if they've got good range of movement. I know on one of the other slides it says the contraindications would be if you've got arthrofibrosis or contracture. But if you actually have patients who have had procedures but actually have a relatively good range of movement with some contracture, and you've never been in that joint before, that's a contraindication. If they don't have that huge amount of contracture but they've had some procedure before, you're probably still safer going in open, because the risk of you encountering a lot of arthrofibrosis in there that may not even be symptomatic but does prevent you from seeing things is very, very likely. So it's something that you need to be sure of. The indications for it are that you have an extrinsic contracture of the elbow that causes functional loss, extension, or flexion. The most common technique is go medial, because you need to gain flexion by excising the posterior band of the MCL. Now, the big thing for this is, as I've just said, you need to elevate the cubital tunnel, and in doing so, you need to handle the nerve. So you need to be very careful with regards to this, being confident on it. Sharp dissection is what's being advocated in my training here, and it's something that I think that rather than the constant traction with the blunt scissors in the fear of, I don't want to put a sharp blade near the nerve. Well, a lot of the guys here who are confident around the nerves will teach you to go and use the sharp dissection without traction, because then you cut through it very gently and you cut through the actual fibrous bands around it, and it makes it a bit safer. This is again just a point of debate. It's not something that you're going to be asked in your exam, but it's something that it is, again, just for your future practice, is something to keep in mind, and just get that confidence with sharp dissection over constant spreading of the scissors, where you're tractioning that nerve constantly, especially if it's already compressed, and you're then stretching it at a point where you can see it, but you're stretching it into that compression area, and then you're wondering why you have an increase in symptoms post-operatively. As I've said already, depending on how you go, it depends on how the nerve is behaving after you've assessed it and also released it. Is it stable? If not, you need to stabilize it, so you need to transpose it. The way in which you transpose it depends if you go with an FCU flexor mass split with the trouser legs over it, or if you simply do a subcutaneous transposition. Again, the evidence of these is equivocal. It just depends on what you feel and what you think is useful. Now, this is your lateral column procedure. So you can see here, you've got your common extensor tendon up here, you've got your ECRL here, and then your brachioradialis fibers are here. Now, you're looking for that intermuscular septum for the ridge. And what it allows you to do then is it allows you to go over the front of the elbow and the back of the elbow. This is your leading lateral edge of your triceps. So you're coming down onto bone here and you're going across, and directly behind this you'll see the olecranon. If you come down here, you're going directly across the front and you'll see the coronoid fossa, and you'll be able to strip the capsule off at this point as well. Here is your column procedure reference point. So there's your bony ridge. You can see from the front and the back and where you're coming across, and you'll be able to get at the coronoid osteophyte, your anterior capsular release, your olecranon osteophyte, and also your posterior capsular release. And you're literally putting in an instrument, sliding it in and stretching it, resecting it, possibly doing a sharp dissection on bone with a blade and releasing it. And ultimately, you're doing everything that you would have been doing arthroscopically, except through an open procedure. This is not as destructive as it sounds with regards to your lateral structures. You're not affecting the local, intentionally anyway. You're not affecting the lateral ligaments of the joint as well. You're coming over the front and around the back. So you haven't actually affected any of the stabilization factors or features of the elbow itself. Generally, it's a limited lateral based incision along the supracondylar ridge. If you're getting into this detail for your exam, you're doing incredibly well. But ultimately, what you need to talk about is what are the indications, contraindications, and risks. Indications: if you've already been in there, you need to come out and go with an open procedure. Other indications would be if the patient has a huge amount of contracture, and like we said, anything more, or rather anything less than 90 degrees of range of movement would probably suggest you need to be considering a lateral column procedure plus or minus a medial approach as well. Biggest risks for this are damage to the lateral complex, and specifically damage to the local. The local is your main moneymaker when it comes to the lateral stability, so you need to be aware of where it is, where it starts, where it goes, and making sure you're anterior enough to it and proximal and posterior enough to it when you're doing your posterior approach to that capsule at that point. Now, this is something that I didn't really have a particular grasp of when I was coming through my training and wondering about your medial approaches to the elbow. And we'll touch on this in the trauma talk for terrible triads as well, but this is quite interesting. On the AO surgical reference website, they give you this lovely picture with numbers 1, 2, and 3. These are your 3 medial approach intervals to the elbow. So the Hotchkiss is a very commonly used one of over the top. And the reason I've written tip, medial facet, and base here is because if you were trying to fix the coronoid, these would be the intervals you would use. Your skin incision is pretty much the same depending on where you've drawn it. And if you make it longer, you can get it all 3. But ultimately, you can actually create all 3 of these approaches through the one skin incision and having different windows. And I mean, we do it when we're doing anterior approaches to the hip with regards to inguinal hernia repairs as well, and you have different windows. Rather direct inguinal approaches to the hip and the pelvis. But depending on what you're doing, you can then change these. And it's just about knowing where your intervals are. Your first one is the border between your palmaris longus and your FCU. That is your Hotchkiss. The next one is just think about your ulnar nerve. You've got two heads of FCU, and if you go between the two of them, that's your FCU interval for these ones. And then if you go through for your number 3, which is your talar and sham, you're taking off the whole flexor pronator mass here. Now, maybe not completely folding it up completely, but you are elevating it enough and kind of going 45 degrees, trying to get underneath it over, and you can get to the base of the coronoid, as you can see being highlighted with the kind of superimposed pencil lines here. These are... Well, in learning these, this took a lot of the fear out of my mind when it came to the elbow and the medial approach, because we often think about it. Medial approach to the femur, scary, not the case. Medial approach to the knee, very scary, not the case. And medial approach to the elbow, even scarier again, not the case. All you need to do is know where the sublime tubercle is, know where the cubital tunnel is, know where the ulnar nerve is, and you know where all these things are, and then you can talk about what approach would you use. Well, if it's a tip, I would use a Hotchkiss. If it's a mid-body or a medial facet specifically for the MCL, I would use the split between the two heads of FCU. And if it's a base, then I'm going to come across and do a talar and sham lift of the pronator mass. So with regards to this then, it gives you that confidence to say, I know where I'm going, I know what I'm going to be doing. The complications of the total elbow arthroplasty are not fun reading. So the total complication risk is very close to 45 or 50%. Periprosthetic infection, again, we're so close to the superficial area of the skin as well anyway. So prior elbow surgery increases your risk, as with any implant. Prior infection, especially staph epi, that's a nightmare. Psychiatric comorbidities, again, this links in with the general kind of compliance and the self-care. Rheumatoid arthritis, bad skin, bad bone quality, bad soft tissue, and probably have been on a truckload of steroids for most of their adult life. Wound drainage, again, big issue that they form hematomas because we're lifting flaps. Reoperation for any reason will increase your periprosthetic risk. And of course, poor skin quality, which touches back onto our steroid use. And the last part is if you're doing a 2-stage revision for an elbow replacement, chances are it's not going to be a good outcome. So there's a lot of issues around this. And there are a lot of people who would advocate a single-stage revision for your revisions of elbow arthroplasty. Ulnar nerve neuritis is very common, and not just for TEAs, but also across a lot of other procedures. So anything around the medial side of the elbow, you need to be aware of the neuritis. I've touched on the fact that if you restore flexion, you need to be aware that you should probably be doing at least a cubital tunnel release, if not a transposition. Other complications as well that come with TEA would be triceps tendon avulsion, fracture, more commonly because of poor bone quality, especially in rheumatoid patients, and avulsion fractures of the olecranon. Aseptic loosening, mainly because you have linked implants for the total elbow arthroplasty, and specifically because you have to have a linked hinged implant because chances are they are not stable. You're not going to go doing a soft tissue stabilization for these patients or a ligamentous reconstruction before you put in a non-linked TEA, so they're going to have a linked one, hence why we put them on such a low weight restriction of 5 kilograms. You can get instability if you put in unlinked implants, and because they may even be stable initially, but they are at high risk then of losing stability because of having a ligamentous injury, that then you end up with an unlinked implant and then the elbow is unstable and doesn't function. So with regards to all this then, I want to just highlight that in the elbow OA, it's a very different beast. It's something that I want you to think of with regards to it's not a direct transfer of approaches from the knee. For instance, you wouldn't be going in doing osteocapsular releases of the knee for stiffness. You wouldn't be going in and doing a direct medial or lateral column approach for the knee. So there's a very different approach to these, and I think firstly you need to understand the anatomy, secondly you need to understand the pathoanatomy, and then you know the natural history, the presenting complaints, and what you're going to deal with. So the final word would be treat the man, not the scan, and treat the picture, treat the patient, not the picture. Make sure you're treating what the main complaint is.